Hello, everybody. My name is Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have a great topic related to prosthetic joint infection, whether we can make this unstandardized standardized. I think this is an amazing topic, and we have an amazing faculty. Well, I will just introduce Nate Heckmann from USC, and he will introduce himself and the rest of the panel, and he's going to be the moderator for this evening. Just remember, if you have any questions, place them in the chat, and we will call on you to unmute and ask. Unless you're somebody from Disasterplasty, where you're probably just going to yell some stuff out. Um, no, okay. So, okay, take it away, Nate.
Okay, well, Ira, first of all, thank you for hosting this. I think periprosthetic joint infection, uh, as many of the other people on this forum can attest to, is a clinical passion of all of ours. Otherwise, we wouldn't be here. I think the data only gives us so much, and we often learn immensely from other people's experience. And so I think this type of forum is extremely invaluable. It can be illuminating. It's very insightful. And so I'm eager to learn from Chris and James's experience and also from the audience as well. As Ira already mentioned, please ask questions in the chat. Ira and myself, while James and Chris are talking, we'll try to get to everyone's question. If we don't see your question, ask again or even weigh in. We can make this as conversational and as candid as possible. And so let's jump right into the meat and bones of this. I'm going to introduce James Baker first. And James, if you could just tell us a little bit about your practice, where you're from, and maybe a tidbit about your interest in periprosthetic joint infection. And then after James, we'll bump it over to Chris, and then we'll get started.
So James Baker, I'm in Louisville, Kentucky. Worked at the University of Louisville. I'm 4 years out into practice now. I did my fellowship at Cleveland Clinic, Florida. Worked with Aldo Riesgo there before he moved over to Miami. My practice is about 40 to 50% revisions. Probably do close to 100 infections a year. So that's my practice.
Terrific. Well, kindred spirit. Chris, share a little bit about yourself. Where are you from? Tell us a little bit about your practice and a little about your clinical interests and clinical experience in periprosthetic joint infection.
Chris Hoedt. I'm in Greenville, North Carolina, the other Greenville, as we like to say around here. Nobody seems to know. Everyone knows the South Carolina one, but it's kind of closer to the ocean area. I'm actually in a private group, but we only work at ECU, East Carolina University Hospital, which is one of the largest hospitals in the country. So as far as infections, I don't do quite as many as James, but over 50 a year. I've kind of developed a close relationship with the infectious disease team here that they tend to refer most of those to me, even though I'm in a private group. It's just dynamics of the area and great opportunity to help out the community and good gig.
And you're known as one of the infection guys, and I think that's great. I think 50 years, still puts you in the top 1%, and so I think you have a lot of experience. I'm somewhere between you and James. I do anywhere from 75 to 125 a year, and I have a unique referral, practice in that I deal with a fair number of failed 2 stages or patients with that have undergone a prior stage intervention, and so that's been a labor of love in my practice. I don't know if James or Chris, have you any slides you want to present? Otherwise, I'm going to get right into the meat and potatoes of this talk. We have lots of topics to discuss. If you guys do want to present some slides, feel free to do so. Otherwise, I'm going to jump right into topic number 1 on our agenda. So first of all, we're going to talk about diagnosis. So I know we have a lot of data guiding us. We have the MSIS criteria. We have the ICM criteria. We have the European Bone and Joint Infection Society criteria, and we have some up-and-coming universal criteria that are going to hopefully bring harmony to the diagnosis of PJI. And those criteria provide guidance for us, but in practicality and reality, the average patient or some of the patients we see in clinic don't fit nicely into one of these categories, and are oftentimes, even when relying on these published criteria, can categorized as inconclusive. I guess, Chris and then James, what is, some of your diagnostic workup that you can share with us? What are some of your diagnostic pearls, number two? And then number three, when you do have this equivocal case, what type of tools do you lean on to kind of push the needle in one direction versus the other?
So like you mentioned, some of the criteria, MSIS, ICM, basically a lot of following those. I think usually when somebody's getting referred to come in, they're having pain or draining wound or a problem. So it's obvious what they're coming in for. I think on the rare occasion, I get a referral if somebody's got a chronic infection that's just on chronic suppression. That's a little bit more of a challenging conversation because usually the way I approach that is we know you're infected. When's the right timing to do something about this? Or should we even do something? Can you get through it? And what are our options? So those can be a little more complex conversations to have with people, I think, because it's a big undertaking if you're going to go for a two-stage. Just how challenging it can be on quality of life if they're still working, emotional dispositions of everything they go through, and trying to help them plan for that as best you can. But yeah, I mean, serum blood work, trying to aspirate the joint, get confirmation. I think it's super helpful if you know the pathogen ahead of time, being able to guide antibiotic treatment plans. I usually try to refer to infectious disease even before we bring them in for the surgery to the hospital. Just that way we've corralled the whole team. Everybody's on the same page, kind of know exactly what we're doing coming in ahead of time. It helps make the patient's experience more coordinated and better too.
No, great pearls. James, what about you? You have a painful joint sent to you, say it's aseptically loose, but it doesn't have a diagnosis of PJI. I guess what's your go-to screening labs? It sounds like that's what Chris does. I do the same thing, ESR and CRP. Say, CRP of 9, ESR of 25. So abnormal, but both below our MSI's criteria. Are you aspirating that joint? I guess what's your threshold to aspirate in that setting?
Yeah, so for a knee, if they're in my clinic and they have a painful joint, they get an aspiration. I think a hip is a little bit more logistically demanding, but a knee is pretty simple for me to put a needle in. So kind of my workup is every joint that comes in to see me that's painful is infected until proven otherwise. I think we probably underdiagnose infection a lot. And if you look at some of the universal criteria that's coming up, like it says that we do that, right? We're going to lower a lot of those thresholds to capture more people. So when you come see me, you get ESR, CRP, you get an aspiration. I send for Snovisher on all those people that I aspirate in the office. The hips, they don't get it just because it's a little bit more technically challenging. But that's kind of my workup. And anybody that falls in that inconclusive, right, it's a little bit of what's your gestalt. Like if I see somebody and like you had a draining wound at some point that healed, and yeah, I really think you're infected, then I'll just say, yes, you're infected, and we're going to proceed down this pathway. If not, and you didn't have any problems healing, things like that, then if you're inconclusive, usually what I'll do is I'll have you come back in and we'll just repeat the stuff, right? Just to get another data point. And if it's inconclusive at that point, then I just talk to the patient about, hey, all your pre-op stuff up to this point is inconclusive. I do think or I don't think that it's truly infected, but during surgery, what we're going to do is we're going to take samples. We're going to do frozen sections and try to find something to guide me one way or the other. And honestly, I'm a big believer in single stage. So like these people who are really on the kind of mark, I think it's easy just to treat them as infected, do the dual setup, single stage revision, and see what the cultures show, right?
So James, you hit on several good points. I'm going to touch on a few of them in a little bit later. We'll shelve the single stage versus two-stage controversy for now, but we're going to come back to that. Just a few pearls I think James pointed out. I think, if you rely on inflammatory markers alone, you're going to miss a relevant subset of periprosthetic joint infections. Those two markers do not have 100% sensitivity. And so you have to go based on your index of suspicion. I have a revision practice, and so I aspirate every knee exactly like James does. I aspirate the vast majority of hips, regardless of their inflammatory markers. Now, it's always important that you have some sense of pre-test probability. And so I'm not recommending that for every surgeon in every scenario. but just by virtue of the patient population I treat and my index of suspicion of the average painful joint that gets sent to me, I have a very low threshold to aspirate patients. And I do find that that's very useful diagnostically. Chris, what about you? You have a painful loose joint. Do you aspirate that person routinely, or do you wait for screening labs first?
Yeah. If I can't get any fluid out because of severe scar tissue or something, and the needle tip just won't get fluid, I still send them for an ultrasound guided aspiration with interventional radiology. Every hip, I send them first to interventional radiology for attempted ultrasound. If that fails, I take them myself for fluoroscopic guided aspiration. We're fortunate in our clinic that we have fluoro, and I can quickly just pop over between seeing patients and do that myself. My screening is Synovusure. If I know that they're infected, but maybe we're not quite sure, of the pathogen because they've got pus coming out of the wound, usually I will actually use Microgen. Our whole institution at ECU has actually switched from a different lab facility over to Microgen now, is what our ID team prefers. So that's what I'll do if I know we're trying to get big cast net to capture everything, just so we don't end up with a culture negative.
Awesome. Chris, I've been using both Alpha Defensin and Microgen DX next generation sequencing, especially to help identify organisms. I guess, James, you mentioned you use Synovusure for 100% of your aspirates. Chris, what about you? Are you selectively using them? And James, sorry, I didn't mean to misrepresent you if that's not what you said. So just, I guess, talk to me about your indications for Synovusure and how's that been, of utility in your practice.
So for me, I do send it on everybody. And part of the reason I do that is our lab is a little unreliable. So I've sent straight pus to our lab before, and it come back with normal numbers, and I'm like, I can't trust that. So I like to have a lab that I can send it to that I know I'm going to get reproducible numbers. I know it's a little bit of extra cost, but to me, it just makes me feel good, right? So.
Yeah. And, I do think it can be cost effective. It gives you other parameters. It gives you a cell count differential. It can identify a pathogen. And then it's bundled with the preoperative care. And so sometimes you can make that cost effective, or at least not eat into the contribution margin of your hospital system. Chris, what about you? When do you use Synovusure? Do you use that selectively? And then it sounds like you do Microgen DX for the vast majority of your aspirates. Is that correct?
So I use Synovusure as more of a rule out. When I don't have a high suspicion, I still test everybody because I'd rather not have a surprise in the OR. The other thing, just a small contribution, the lateral flow in the OR test, I finally have gotten approval to start doing those. So we're getting ready to kind of make that part of our standard protocol in the OR too. But I've still been sending frozens and fluid sample even when we've confirmed everything, just as another data point. The issue is that on my standard, especially knee revision, we've gotten so efficient that there's no way that pathology or even the lab's calling up with a cell count before I'm ready to put implants in, if it's a primary. So it's one of those situations that more data, the better in my mind. I don't want to miss one and end up with a patient have a problem.
Yeah, no, Chris, and that's a great point. You don't have cones and cemented stems in a patient and then learn out that they have, MRSA right after. So I think that's a great point. We'll touch basically on lateral flow. So James, can you tell us a little bit about what lateral flow is? We've talked about histology. I think lateral flow, which is invaluable to have a bedside point of care alpha defensin test, has been useful in my practice. I guess, how is that played into your workflow? I guess, do you use that intraoperatively when you have a preoperative workup that's equivocal?
Honestly, I'm usually not using it. Sometimes I'll use it on the hip, but just because I'm sending everybody off for Synovusure for the knees, I don't really feel like it adds a whole lot because I've already done an alpha defensin on them. For the hips, where have that kind of, I'm not sure, and I need another marker, then we'll use it. But that's where it falls in my practice, is those hips that are kind of unknown.
Awesome. It's binary. It's like a pregnancy test. It's either yes or no. So you're not 50% pregnant, you're 100% or zero.
Yeah.
We have a question from the great John Minter. So I'm going to direct this to James and Chris first, and then we'll ask the audience. But anyone, James and Chris first, do you guys do an open biopsy, particularly when you have a dry aspiration? Yes or no? And then we'll ask the audience who else does that here. James, what about you? Any role for an open biopsy?
So I think it can make sense. I personally haven't done it. I think I'm pretty good at getting fluid, so I don't end up with that many dry taps. And honestly, that's where I go off of a high index of suspicion. If you have elevated inflammatory markers and you make me think that you have an infection, then I'm going to treat you as infected. So,
Chris, what about you? Any role in your practice for open biopsy?
I don't. Maybe 5-10% of knees I can't get something on just because of scar tissue, and that's why I'm doing the intraoperative stuff anyways. So I don't open biopsy.
And then anyone in the audience, does anyone do open biopsies? Okay, and then we have another question.
Nate,
What
I
kind
think
of work?
John is on here. John, you mind popping up and telling us what you do for those?
And John, specifically, can you talk about your indications as well? I think that'd be extremely helpful. Oh, you're muted, John.
Yeah. All right. So what I find is, especially for the patients that are arthrofibrotic, that a lot of times just putting a needle in there just doesn't always get it. You may not really get enough to really have any kind of clear um, if you're trying to go into this surgery with foreknowledge, and you really want to know who the enemy is, then for me, it's really critical for me to understand that. So I really want to have all my bases covered before I go in, because it also helps me direct my treatment. There's nothing worse than getting caught with a fungal infection that you thought maybe was a bacterial infection, and you kind of find out sometimes even too late, because wouldn't it be great to load up a bunch of amphotericin in your cement mix, but then you don't really get a culture report. And that's where microgen is so great now, because and that's what I do. I mean, I send culture and microgen. I've kind of gone away from Synovusure because it's influenced by like metal debris and things like that. So yeah, I mean, I'm definitely shooting for aspirations, but there's just certain scenarios where it just does not come through. And so whenever I see a patient's infected, I'll go ahead and I plan their biopsy, but I plan their subsequent surgery at the same time. I'm kind of hedging my bet. And usually, it's just a little arthrotomy, and you get all the tissue specimens, do all that stuff. But anyway, I just like to kind of know before I commit. And so that's part of what I do. I mean, I don't do a lot of them. I just think it's important to consider it when you don't have a diagnosis. So
Great pearls, John.
yeah.
And I think one of the common denominators that James, Chris, John is saying, and I share is, the more data you can have going into surgery, the better. You never want to go into any type of big intervention with a information deficit, especially if it can be addressed with some type of pre-operative or pre-surgical diagnostic workup. We have more content to cover, so I'm just going to skip past diagnostics unless anyone has any closing remarks or pearls. Let's talk about, debridement strategy, debridement techniques, and also not just the surgical debridement, but the chemical debridement. What are we doing, to irrigate? How are we eradicating biofilm after we do our surgical debridement? And so, James, can we start with you? I guess a standard infected primary knee in a type A host, what's your just bread and butter PJI, surgical debridement? How do you resect implants, remove bone? What are your debridement tools? And then how are you chemically debriding?
So for me, I think it's important to do your debridement on the way into the knee, right? Don't wait to get implants out to start doing it. So once I make my arthrotomy, I'll really resect the medial and lateral gutters and get good tissue planes on both sides. On some people that I'm really kind of concerned about the quality of debridement, I'll do methylene blue just to have that dye in there to help me. I really do that early on with the fellows so that they can kind of see and learn. I think as we get further along in the year, they get better at it. So I don't do that as often. But good debridement there in the front of the knee on your way in. Take the femur and the tibia out. And then I like to use the Avitas to help with the bony debridement. I think it does a great job of cleaning out the canals. It really gets any film off of it, especially for cemented stems or press fit stems down the canal when you're revising the revision. And then for me, the next big thing is making sure you get a good debridement behind the knee, right? So you got to get that posterior capsule. I think that's the scariest part for a lot of us. There's bad things that live in the back of the knee. I think if you're doing a DARE, so you're leaving implants in place, the Avitus is a great way to be able to clean back there some, just because it fits in between the components very well, and you can clean out the back of the knee. Once you get done with that really good mechanical debridement, that's when we go to a chemical debridement. For me, it's a combination of full strength betadine and peroxide is my first solution, and then rinse that out with 3 liters of saline. Then I'll usually go to back to Sure. I know it says you're supposed to just irrigate it in and out. I'll actually let that sit for a couple minutes, wash that out, and then for most of my infections, I'm doing a clean to dirty setup. So that's where I'll put acetic acid in the wound because it takes a little bit longer time to work. Leave that in the wound what time I make that transition from clean to dirty, and then come back and wash that out with 3 liters with new drapes and everything up and new instruments.
Awesome, James. I do something very similar. Chris, what about you? Anything different from what James articulated? Any technical pearls?
I mean, similar subtotal synoviectomy. I use a Cobb, trauma style, and I just scrape. So, I'm scraping the periosteum on the tibia, the femur, everything I can get access to, and even that posterior capsule. I use a Cobb on it. Obviously, I'm trying to be cautious and check so I don't have problems. I actually drop tourniquet on every revision knee that I'm doing. I don't always use a tourniquet on primaries, but especially on a revision, I usually do. But I'll drop tourniquet, making sure I didn't have a problem or anything. Luckily, I have not had that yet. I'm sure the day's coming. But yeah, I'm very aggressive in that regard. And then, curettage, my PA is pretty good at helping me find those little pockets of cysts or something that'll exist in there. I use Avitus on anybody who's got stems as well. Basically, anybody that doesn't know, it's kind of like your reverse curettage Moreland, but with suction. And there's a little canister that will collect all of your tissue, which is awesome for being able to send that off for culture too. Just makes it easier to collect. But no, very similar on hips. I think it's a little harder on a hip to be able to get as good of a thorough, systematic debridement per se. I'd love to hear what other people are doing. But for me, it's just reaming out, acetabulum, stem side, again with the Cobb. I'm just pretty big on that sort of treatment method of just scraping and cleaning all the necrotic tissue. I wash out real quick. I usually start with back to Sure. My theory is that should break up the biofilm the best initially. So that's why I start with it. Then I actually will follow up with Dakins, and I'll go ahead and soak in Dakins. Obviously, normal saline between all these. You don't want the Dakins to mix with anything. Lots of publications on that being very bad if Dakins mixes with anything. So very thorough saline between. And then I'll actually finish with my betadine is sort of my last irrigation. But that's just kind of my standard.
One of the
Chris,
things
awesome.
we didn't really touch on that we should is when you're doing that thorough debridement, make sure you're taking your cultures, and you want a minimum of 5. So for me, I do synovial fluid, I do medial and lateral gutter, and then femoral and tibial canals to make sure that I get kind of a broad sampling of tissues from the knee.
And Chris,
maybe sinus tract would be the only other thing I would add.
Yeah,
Chris, I think you bring up a good point too. You can use the Avitus to take the intramedullary contents for culture, and I think that's invaluable. It can really get, if you have a loose infected stem, that membranous film that forms in the diaphysis. You could debride with that with the Avitus, and we routinely send the Avitus contents for culturing, and that is a fairly high yield. For chemical debridement, I do something similar to James. I like to do the betadine peroxide first. I find that the peroxide, just like when you put it on a scrape, it dissolves blood, and it actually helps lavage out a lot of that gross debris. And then when you use concentrated betadine and peroxide, it actually really, it has a very effective anti-biofilm activity. So it also disrupts biofilm. And some of Nick Berntal's data out of UCLA has shown that very nicely. But I do follow it with Bactisure. I think that just has a very compelling data to eradicate most biofilms. And then I usually chase it with Aricept or a dilute chlorhexidine wash, just because that's has very high efficacy for planktonic organisms. So once I've done my surgical debridement and my chemical debridement to try to nuke biofilm, I then try to aseptically clean out the surgical bed before I flip. There's a couple of comments and questions. Actually, Dr. Siegel, a great question. I don't know if you want to ask this or if you want me to ask this, but Dr. Siegel's on, so maybe Herrick, if you want to
You
weigh
can
in.
go. You can. I'm just curious if you guys treat your own infections similarly to those that are referred in, or do you feel like you may be addressing them earlier than if they're being referred in, or more comfortable leaning towards a dare or single stage rather than something more aggressive?
Great question. Chris, how do you want to answer that?
I sort of want to check everything early. I'm not the like ostrich type who wants to put my head in the sand and hope it goes away. So I'll start getting serum labs the second that there's any sort of question, any drainage, any erythema around a wound. I'm like automatically wanting to get serum labs and trend them. And then the second anything starts heading more south, because I'd rather be able to hit that acute phase and be able to try doing a dare.
And then,
usually
Chris, I think one thing Herrick was also getting at is, are you more likely to try to dare your own patient and salvage? Or I guess, the fact that it's your patient, does that bias or change your surgical intervention at all?
No, that's what I was getting into. I don't usually get referred patients, frankly, who are in that acute phase window.
Yeah.
Usually, they're outside that window by the time they've made it to me. And so
Same.
I don't really, I mean, if somebody really wanted to try, I've had a couple patients who we've tried doing a double dare on. I always use antibiotic beads too for the MBEC, the minimum biofilm eradication concentration concept. And it's been successful for a couple people, but I tell them there's a high risk of that not being successful. But if they really don't want to go through something more aggressive.
Awesome. James, what about you?
Yeah, I think especially I do a lot of press fit knees and obviously press fit hips. So those in the acute phase, I'm more likely to rip everything out and do a single stage revision because it's easy to get them out at that point, right? If it's revision with well cemented stems and things like that, then obviously I'm going to try a dare, double dare early on. But if it's my own primary joint, then I'm much more likely to do a single stage revision early on. So
Great points. Question from John Minter. I know John's answer, and I think, John, you know my answer. But who here is doing a double setup procedure with a distinct dirty and clean side?
I do it on everybody. Every infection gets that, even if it's just a washout.
Chris, what about you?
Yeah, same. So we have another set of instruments and then another table available to be able to convert over. I'm just even more meticulous if I'm doing a single stage, kind of like James has mentioned, where we're breaking down. We've got a whole nother setup of drapes, everything like light handles, everybody breaks scrub, like extensive.
Yeah. Same here. We do about 300 of these double setups a year. Provocative question for John, and then for James and Chris. You guys are doing a 2-stage protocol, and every biomarker, every clinical scenario, every exam finding would suggest that patient is clear of their infection, that you have source control. You're taking them back for their aseptic second stage. Do you find there's any utility in re-debridement and doing a repeat double setup?
I can tell you that I used to do that before we had such good sort of more definitive lab stuff. Example, microgen, because I absolutely am going to get all the information I can on the front end. But I think my confidence level is a lot higher. But I definitely used to do double setup when I would take them back, because we just cultures. I mean, they don't always tell the whole story. Let's face it. Even when you think like the cell count is normal, I don't know. I tell patients I get paid to be nervous. So
yeah, I do a double setup on the second stage. I don't do as many two stages as I used to, but I'm always afraid of a local dormant nidus of infected tissue that is sequestered away from the synovial space or shielded from the host immune system that isn't going to show up on exam. And so I always do a radical redebridement of the synovium and recut bony bed. And, in about 1 in 20 of those cases, some of that tissue will show up positive, and the preoperative diagnostic work is still negative. So,
Yeah.
Chris and James, what about you guys? Do you guys do a double setup on your second stage, even if things look pristine?
Yeah, I do a double setup on everybody that has an infection or has had an infection. I think if it was me, that's what I would want. So that's what I do for everybody.
Perfect.
I
And
have
then
a quick question.
Chris.
A quick question for you. How long do you think it takes for the second sterile field to be infected? Because you don't think the infection is cured by the time you're done debriding, right? So there's theoretically still infection at the end. You just can't necessarily.
I don't know,
Harry. I
Eric.
think it's cured, and the second setup will be sterile for how long?
Well, it depends. I mean, it depends on whether or not you think you have eradicated any planktonic organisms. It's a philosophical question because people have tried to answer that after a chemical debridement. Can you identify any living organisms in the field, in the surgical bed? Now, the infected tissue that you have on the back table that is still purulent, that hasn't touched, beta and peroxide, certainly can grow organisms. But can anything within the knee at the time of implantation of the spacer after a chemical debridement, is there any living organism in the knee? I don't know, but surgeons have tried to quantify it, and the answer is we don't have any way to culture those types of bugs. They've even done NGS studies. So, great question. I don't know the answer.
I think it's about just lowering your bacterial load as low as you can, right? So if you're using dirty instruments to re-implant, those have touched bacteria at some point. So why not have new instruments that haven't touched, just to lower that likelihood? So no, the field's probably not sterilized, honestly, right? But you've lowered that bacterial load much lower. So why reintroduce that with dirty instruments?
Right. Common philosophy we all share, whether or not we believe in a double setup, is minimizing bioburden to the best of our ability. Let's jump on. We have lots of questions. Interesting to hear other people's answers. Who here uses local antibiotics? Who here uses a local antibiotic carrier to deliver antibiotics, such as a calcium sulfate additive? We'll answer those questions, then we'll talk about antibiotic holidays. So James and Chris, and then we'll open up to the audience. Local antibiotics, and then any type of calcium sulfate delivery.
I do. I use antibiotic beads and a lot of aseptic revisions as well as septic revisions. I'll use it when I'm cementing the canals. I'll use those beads as cement restrictors, and then also put some in the joint. I think being able to put the calcium sulfate beads in the canals helps with issues that we've had with wound drainage and things like that. So I kind of encapsulate it, but still get the antibiotic delivery. And then the other thing I've been doing since I went to ICM last year is a lot of intra-articular catheters and local antibiotics. That way, I think the data those guys presented is pretty overwhelming. And I think that's probably the way of the future, honestly.
Great point, James. What about you, Chris? Anything to add to that?
Very similar. I do the calcium sulfate beads, same, putting them in the canal, just trying to get that high antibiotic concentration in addition to the cement in the spacer. Everybody complains that they drain, and that's just a known thing for me. So I do an incisional wound vac for all of them. They don't drain right away. It's usually like a week or so after that they'll start having something like that pop up. And not everyone drains, but it's a common frustration to have to get them through and deal with. When I've tried to bring up doing something like the intra-articular antibiotics, I've had too much pushback here, but there's some technologies like Osteal or other stuff coming down the road that I'm hoping will make some headway on those fronts that I'm a big believer in. But for now, with the calcium sulfate beads sort of being the only thing I'm aware of on the market available, that's what I've been focused on.
No, Chris, great points, and James, great points as well. BTX7 is a device that is FDA approved for failed prior two-stage. And then James, I know Leo Whiteside and others have talked about the Heckmann catheter, and there's great data coming out of China now showing the efficacy of that. I think the hardest challenge, at least for us logistically, has been getting your pharmacy on board with it and getting your hospital on board, because it's more of a hospital multidisciplinary logistical challenge and a surgical challenge. I guess, James, do you have any pearls or, having done that in your group, I guess, how do you get buy-in from ID, from pharmacy? Um,
Yeah, so I have an OR pharmacist that I work really closely with. We have a good relationship just with the number of infections and spacers that we do. So he actually helped me work through the workflow of the hospital to be able to get things set up. And he will order those intraarticular antibiotics for us as we do the surgery when we order the antibiotics for the spacers. So having someone that you know and can work with and help you through the process is certainly helpful. And then the other thing is the administration of the antibiotics on the floor and how to work through that. So when we started doing that, we would have issues with getting the antibiotics up there, and then we eventually got pharmacy to put them on the floor at all times, and it just made things a lot easier. We have a nurse practitioner that rounds and administers them. So the first month was difficult, but now we're almost a year into it, and it's pretty seamless.
Awesome. I think there's going to be a lot more data coming out on that practice, and I think in the coming years there are going to be some newer technologies. I'm conflicted because I'm investing in one of those competing products, but local antibiotic delivery, I think, has a role in the future management of PJI. We have a couple more topics we wanted to cover, so I think we're going to move on. Let's dive right into a very controversial one. And James, I'm curious to hear your talk on this topic in particular. But let's talk about single stage versus two stage, and then we'll touch the antibiotic holiday question that came up in the audience while we're talking about the two stage. But what's your indications for single stage versus two stage? And then do you think there's a role for 1.5 stage, or do you think, as Abdul calls it, is it a 0.5 stage? Is it really just a de-escalated, crappy version of a single stage? So James, I'll punt it to you, and then after you answer indications, we'll talk to Chris, and then we'll pull the audience as well.
Yeah, so indications for me, it's always nice to know an organism, but when you really look at it, it's unknown organisms, not a reason not to do it anymore. I think the most important thing is making sure that you do a good debridement. It does need to be a double setup. Obviously, no single stages in a single setup, at least in my world. And I think indications are good soft tissues, a decent host. But honestly, sometimes the host, even when they're not good host, and I know that it's going to be a bear on them to go through multiple surgeries, we'll talk about does a single stage make sense or not. So I personally am a big believer in single stage. I think, especially you look at the data out of North Carolina, right? It's non-inferior. But the big important thing about that is how regimented they were making decisions and what they were doing. So I think if you maintain that regimented standpoint and you can help patients get through with one set of surgeries with the same outcomes as a second set of surgeries, it makes sense. I think a lot of times we default to a two stage just because we're afraid of putting in well-fixed implants. And my thought on that is the failure rate of a single stage is about the same as the failure rate of a two stage. So if my two stage fails, I have well cemented implants, I have cones, I have all these things, the same thing that I have after a failed one stage. So that doesn't really change things for me in my eyes. And then I do think there is a role for a 1.5 stage. I think it depends on what you define that as, right? It's very different now than what it used to be. I think a 1.5 stage when we started it was really just a CR femur and an all poly tibia. But that's not what most guys are doing now. Like John uses the signature orthopedic stuff, right? Like that's basically become a single stage with the ability to take it out at some point. So I think there's a lot of variation in what we're calling what. So, yeah.
Yeah, James, all good comments. Chris, what about you? Have you dabbled with single stages? If so, what are your indications?
Yeah,
And
I
then
do a little
what do you think
more.
about durable spacers? Are these so-called 1.5 stage constructs?
Probably a little more conservative on the single stage side, but definitely have got a couple dozen out there. Got to have an identified bacteria first. That way I know that it's one that's more amenable. to single stage and I'm more confident in. I always, again, get in care coordinated situation. They have to see ID first. I check with my ID colleagues, make sure they're in agreement that we think this is a good thing to proceed forward. And also kind of the social dynamic for the patient. Are they going to be able to follow through on getting the antibiotics? Because that's been an issue for some patients around here when we try to put them through a 2-stage, is they can't actually follow through with the PICC line or antibiotic course or things like that. So if any of those sort of criteria aren't really met, poor host grade, if somebody's B plus or a C kind of type thing, that I'm like, they're on dialysis and they have all these other kinds of problems and issues, I might not be as willing to give them that opportunity or chance because the risks of failing are too high. 1.5 stages. I've got a few hips out there that we had done that for, and a couple of them that were even in working in the healthcare field said, I'm feeling pretty good. I don't think I want to do the next one. And I said, well, when it loosens or fails, come back and let me know. Not as common, I guess, for me on the knees, but I think I've got 2 out there that are just, they'll come back when they decide they're ready. Or
Okay, no, great comments. We're getting a lot of questions too. So Herrick has a good question. Maybe we'll direct this to James because you seem to be far advanced in the single stage journey. Does it matter for you if it's an infected primary versus infected revision? How does that factor into your calculus, or is it really based on host and whether or not the bacteria is sensitive to antimicrobial therapy? I guess what are your factors, and does revision construct steer you towards or away from a single stage?
Yeah, I mean, I think it depends is the real answer to that, right? Unfortunately. But it doesn't really deter me from it. There are some constructs that I see and I'm like, oh man, this is going to take me 2 hours to get out because this is a long cemented stem and this is other problems that I know that I'm going to suffer with, right? So then I'm thinking, okay, doing a single stage with a dual setup and having to reconstruct all this is not going to be time effective. And then I'm going to have the patient open for 3 or 4 hours, and that doesn't make sense to me. So if it's a simple revision that is in and I feel like I can get it out pretty reasonably, then I'm fine doing a single stage on it. If it's one that's going to take a long time, then I'm more likely to do a 2-stage just so that I can break up that surgery time for them and not have them open so long. The other thing that I've done for some patients that aren't great hosts is kind of a rapid 2-stage. So I'll bring them in, take everything out, put a static spacer in for a week, and then we'll use Veriflow into the wound during that week. Some kind of irrigating antibiotics for the whole week, and then bring them back after the week in the hospital. I know what the organism is. I can target antibiotics, and then we'll do a replant. So that's the other thing that I've done on some people that I didn't think were great candidates for 6 weeks to 3 months of a 2-stage procedure.
Got it. Great pearls, James. Chris and James, we've had a few questions come out through the thread just talking about spacer constructs. And I know, James, you've trained with Aldo, who has some very creative durable spacer constructs. Can you guys both each individually go through your standard knee spacer construct and hip spacer construct, James, and then Chris will have you do the same thing?
Okay, for hip, I usually will do a freedom constrained all poly cup. I'll put some screws into the acetabulum, both into the ilium and down into the ischium, and then cement that liner in behind it. I think that ischial screw is very important because it really helps give it some rotational stability and makes them more durable. And then on the femoral side, if I did not have to do an osteotomy, then I'll do a Wagner cone. I'll cement that I'll place high dose antibiotic cement around that just to cover the kind of ingrowth area, but we'll leave the splines themselves available. And that gives me both rotational and axial stability, and it's a pretty long-lasting construct. And then if I did have to do an osteotomy, I'll use a Wagner SL, so a monoblock stem. For the knee, if I'm really doing a spacer, I guess it depends on exactly what's going on. I don't do a ton of spacers for knees. If I need to, honestly, I'll do press fit PRK stems, and it's a very, very long lasting, durable spacer, but doesn't have cones for bony ingrowth and things like that. So that's I was doing when I first came out of practice. I would do a metal femur and then take a all poly tibia and put some sort of stem on it. And man, those will just loosen faster than I enjoyed. And I was taking people back to surgery for aseptic loosening at 18 months. And I'm like, why am I doing this? This is, if I would have just done a single stage, then I'd be done. So that kind of swayed me to more single stage.
No, great answers. Chris, what about you? What's your standard hip spacer construct, knee spacer construct, and any other pearls?
Yeah, so for a while I was doing the stage 1 stem, but not the head, and I was doing a poly liner and then plus or minus a sprue, depending on how well I thought the cement fixation was. Ended up having a couple of those dislocate though, just because we're not putting it in as precise as final implants. So I got frustrated. So lately what I've been doing for the last 9 months or so is just the full stage 1 spacer. So it's just basically a Hemi. Put a little bit of cement up at the top just to help control rotational stability, things like that. It seems to be working fairly well. Haven't had the dislocations, and so it's been working pretty solid for me. On the knee side, it just sort of depends. If it's a primary, I'm actually doing a PS femur with an all poly tibia. I can actually share with you guys because I had something a little prepared.
Nice. Let's
this. Hopefully this is coming across fairly well. Does that look good?
Looks great.
Okay, so this just shows the Avitas for anybody who's not familiar on the right side real quick. And this is some tapestry stuff that I've actually used frequently in infections for tissue issues. So it's just great. This is actually coming back in a second stage. We've actually taken pathology samples and you can even see how vascular it gets. But this is some of the spacer stuff. So this guy was a revision that was infected. We actually took a stage 1 spacer with an all poly tibia just to build it up enough. I thought it was a huge win that we got an articulating spacer for the guy, because usually I just do the all poly tibia and then the femur with antibiotic beads thrown in there too. Of course, the guy's feeling so good and he starts going up and down steps and he flexes past 90 and told him he shouldn't do that, and he dislocated the thing. So then I converted him over to a static spacer. And I just do a carbon fiber X-Fix rod when I do those, just because it's cheap and reliable and durable enough to get them through it. But that's my standard usually for a knee. Just depends what sort of bone stock we're dealing with.
I can show a hip spacer if you want me to, Nate.
James, please do. Yes. And I love how you're influenced by Aldo. I love the monoblock tapered spacer constructs. Do you coat those in cement the way Aldo does? I don't know if you said that already. I may have missed that.
Yeah.
Nice.
Let's see.
And then Chris, those were some great, tapestry cases, and that histology data, that histology slide's just super compelling.
Yeah, I've been pretty impressed with it. And there was, some concern of when you're putting this in an infection case, is that going to be something that leads to a problem or persistent infection? But I haven't seen it yet. Again,
James, love what I'm seeing so far. Walk us through these slides. This is fantastic.
Yeah, so this is what I would call more of a single stage ish procedure, just because we put a real cup in. But this is a Wagner SL. This is I'll kind of show you her. This is where she started. So she had a monoblock revision stem in. She had previously had a femoral neck fracture. So I went back in with a longer stem. So this is a Wagner SL. So basically all you do, you can see how those splines are kind of uncovered, so that when you push this down in, you're still going to get some cement in there to stop that long-term kind of on-growth surface to the grit blasted, but it still gives you that axial and rotational stability, and works out really well for me. And they actually, so Aldo and those guys published on that, and this is actually a picture from him, but they had a great kind of outcomes with these. So this is my hip spacer of choice. And honestly, I do a fair number of these, and I've revised 0 of them for femoral loosening. And on the cup, like I said, I'll do that freedom constrained liner with screws both into the ilium and down into the ischium. And the only ones that I've revised the cup for loosening is the ones I didn't put the screw in the ischium. So that's a very important little thing to put that screw in if you want it to really have stability. So
yeah, great pearl. And James, that constrained liner is unique. It has a 115-degree impingement-free arc of motion. And I think it really lends itself to being cemented in. And we have a series we published in Arthroplasty today with that liner. And it has a fantastic, track record of being used in that setting just because of its unique design. The only thing worse than a hip spacer is a hip spacer that's dislocating or loose. And so avoiding instability is a huge part of being an effective PJI surgeon of the hip.
What phase is that cement in when you're putting that on the stem and then putting it in the patient? Is it still setting, or
yeah, it's still setting. So it's not hardened all the way. I let it kind of get a little doughy before I put it on, and then wait a couple of minutes while it's definitely not set all the way and still pliable when I put it in. So when you push it in, it'll push some of that off of it for sure.
Okay, thanks.
And you want to make sure to fill the valleys, but don't cover the peaks, ideally.
Yeah. So I'll
take doing it in the doughy stage helps.
Yeah. I'll take a tongue depressor and actually run along the valleys so that it pushes the cement into it. You got to wait until it's at the right moment, or you go to do that and you just peel it all off. So it takes a couple times to get it.
That's why I asked, because it does fall off.
Yeah. Takes a little experimenting.
Okay, guys, we're gonna just talk about the last. There's 2 topics. Really quickly, what do you guys do for soft tissue management? Who here uses wound vac, and who here shuts down the knee at least for a short duration to allow for the wound to heal more readily? James, what about you? Wound vac,
Prevena on everybody, and then 2 weeks in a knee immobilizer.
I do exactly the same thing for knees. Chris, what about you?
I don't do a knee immobilizer, but they all get a hinge knee brace, and I kind of block them. No, nothing past 90, but pretty similar.
Yeah. I do Prevena Plus on most people, and then I restrict motion almost routinely for 14 days. I have not paid the price with respect to stiffness. I get them moving at day 15, but my drainage rate has dropped. Steve Weber has a hand up. I don't know if that's on accident, but Steve, do you want to ask a question? And then we'll jump into our last topic on prophylaxis and prevention. Is that a ghost hand or an accidental hand up? Okay, let's talk about our last topic. What am I doing differently in 2026 for PJI prevention? So let's talk about primaries and revisions. What are you doing that's unique today that's probably different from what you saw 3 to 5 years ago in training for prophylaxis? And then talk about your primary prophylaxis strategy and your revision prophylaxis strategy.
Biggest change for me this year has been the use of experience. I think there's some data behind it. You wash it out and leave it in. So for me, I think there's some data there. I still use the sterile betadine, so it's pretty cheap rather than a pre-bought, pre-diluted. So I offset the cost there in my head, so it makes sense. And the thing that I do for revisions is use those the beads within the canals just to add that local antibiotic delivery for a while. I don't have the data, but it makes me feel better.
Okay, so aseptic irrigant and then some type of topical delivery. Chris, what about you? Anything different?
Pretty similar in that, I mean, for me, the Dakins is the only non-sterile solution I even use on an infection. But I mean, I use sterile betadine even for primaries. I think one of the biggest things that I've tried to pay more and more attention to is applying the revision world to even primaries. We got to pay more attention to our host grade. And so I really try to pay attention to their nutrition status, things like that. I make sure to tell everybody they got to be getting enough protein as they're trying to heal their wounds and get through everything. So I'm paying attention to that. And I've developed the, as my medical assistant in the office knows, the smell test. If anybody smells bad, it's a big concern about hygiene issues. And I frankly just have that confrontational talk with the patient as gently as I can. But if I have any serious concerns about it, those seem to be the people who are going to end up getting infected anyways, people that have hygiene problems.
Chris, from your mouth to God's ears, though, I mean, nutrition, is something that we don't talk about enough, especially protein malnutrition. I give that talk to almost every patient. I tell them, this is the only period in your life where overeating may work in your benefit and diminish your likelihood of having a life-altering complication. It helps your body heal. It helps you prevent an infection. It helps you fight off an infection. And this is doctor's orders. You have a 3-week sheet period. So I encourage them to eat excessively the week before and the 2 weeks after surgery. And I think that can help you stave off preventable wound complications and prime the host body to fight off the infection. Ira, how much time do we have? I guess, do we have time to go over? Or is this 1 hour? You're muted.
Rookie mistake. Sorry, we can definitely go over. You're witnessing the fastest hour in orthopedics. But no question, it's worth going over. This is a power topic.
Awesome. So, there's a couple topics, and I do want to hear, from, people like John, Richard, Herrick about these topics. Paulina answered a very important question. What are you doing to support the patient's mental health during this process? So mental health issues are huge. This is very taxing on the patient mentally, physically, and also their family. It can strain them emotionally, physically, financially. I guess, what are you guys doing beyond just being a good orthopedic surgeon? How are you helping patients through that process?
I think my PJI clinic is mostly me paying therapist a lot of times, right? Just whether it's the diagnosis and telling them the plan and help them through that, or it's the anguish of the 6 weeks of IV antibiotics and you're 3 weeks in and you're throwing up because you can't tolerate the antibiotics. Like this is it. This is the cancer of orthopedics, right? So I think you got to take your time. You really got to spend and talk to patients and help them through it. And I think the more you can set them up on the front end for what they're going to go through and help them understand it. And again, I really like to talk to patients in terms that they can understand, which is cancer, right? We all understand when you hear the word cancer that it's bad. But I think when we say the word infection, a lot of times it doesn't really click for patients who don't know. Just because you take a couple antibiotics, you get rid of infection, right? You have a sore that gets infected, it's done. That's not this, and it really takes some time and talking to the patients to get that across. And I think that's the part that becomes undervalued in what we do. So that's an important question, an important point.
Yeah, I've got a great care coordination team. So we have orthopedic transition care nurses who actually call the patients, follow up with them, help intervene on everything. Misty's great at that, especially from our team. And then I tell them when we're talking about doing the surgery, I cite all those same things. I tell them this is basically similar to going through cancer, mentally, emotionally, a PICC line similar to kind of like a chemo thing. And that's exactly how I explain it to them. Tell them that if they don't have a therapist already, they might want to get one. If they do have one, they need to touch base more frequently. If they have a psychiatrist or on medications, they may need to check in, change dosages, kind of get prepared for all this with their family. Talk about finances, all those kind of things as we're heading into this, because this is a massively life-changing thing to go through.
Yeah. Chris and James, go James.
I was just going to say, this is one of the big things that we're really behind on compared to Europe, man. The multidisciplinary teams and the way that they coordinate the care and just work through everything with patients. But the problem is we just don't have the funding, and the U.S. healthcare system doesn't work this way, right? It doesn't make a ton of sense. So that's one of the things that everybody on here and everybody that does this really needs to advocate for is the funding and the way to do this in a better way. We need statewide PJI treatment centers the same way as we have the National Cancer Institutes in each state that can help coordinate and get patients into the right place and provide all the correct resources. So I think that's something that we need to push as a group of people who care and take care of these individuals.
Yeah, definitely agree. I think PJI work in the U.S. is undervalued, underfunded, and it does our patients a disservice. Chris, I do the same thing you and James mentioned. When I talk to these patients, My first conversation is really geared towards making sure that we have a mutual understanding of how severe this is. I describe every PJI as a life-altering, devastating complication. I tell them that even in the best scenarios, even if I do the world's best surgery and you're 100% compliant as a patient, we can lose this battle. But then I tell them I'm never going to abandon them. And I'm always going to be their friend, and I'm going to get to know them whether or not they like it for the rest of their lives. And then this is where I need to set better boundaries. I give most PJI patients my number. So I have about 700 families that have my cell phone number, and I get a cell phone about once a day that usually provokes a knot in my stomach. But 3/4 of the time, it's for something good, not something bad. So you have to be there for your patients. Your patients are more than the sum of body parts. They have hearts and emotions and problems to deal with. And we have to treat their orthopedic issues, but also treat them as humans. Last question from, let's see, Kevin Plancher. Why do you think we are getting infections? Is it hygiene or a complete lack of
I can,
maximizing patients' health? So
Nate,
I don't, Kevin, do you want to jump in and
yeah,
ask
I'm
this?
just saying this has been amazing. I caught on late. I apologize. Congratulations to all of you. But maybe we have to take a step back. Why are we getting all these infections? Don't we have to look inside ourselves? Are we not doing what we are? We're not just technicians as orthopods. And maybe our internists are putting us down. Maybe we are. We're not maximizing maybe the health of the patient. And we have to learn to say, you're not ready for the joint. I don't care how much pain you're in. You can't have a joint. It's not about the money. And I don't know the answer, but I will tell you we have to solve it. And I'm so glad we're all working on it to do it, but not technically, not get there to get the infection at all. It's just a thought.
Kevin, great thought.
Uh,
And I completely agree.
Yeah. Hey,
Richard?
guys. Yeah, he's got a great point. And something else missed, and me and John have talked about this. You guys all missed we had COVID, right? We have a real problem here. People are immunocompromised more than we think. And the things we used to be able to treat, we've talked about this, we can't treat as well as we used to. We have a lot of failures, a lot of wound problems, a lot of things. And it's not because we're not making the patients better in terms of malnutrition and those kind of things. We're seeing more failures than we ever did before. I think we're missing a point. There's studies out there that show COVID has hurt us a lot more than we thought. And this is becoming a big problem in a lot of patients. But our biggest problem is the ethical nature of everybody. We want to do good and help somebody, and we think we can help them. And you help them by saying no sometimes. Right? You have to maximize them. If you don't, you got a big problem on your hand, because once you have a disaster, right, it's a huge disaster, just like you guys talked about. And then they get depressed, and then they get upset, and then they go see 3 and 4 other doctors and have 20 surgeries, and end up with the amputations. Right? You should have said no in the first place sometimes, and that's hard to do. That's hard to do.
Richard, that's sage advice. I think as trainees, as residents, as surgeons young in practice, we're taught to say yes to everything.
Yep.
But the harder conversation is learning when to say no. And learning how to say no is actually a lot harder than learning how to say yes. And then the
Very hard.
wisdom that comes with experience about when is the right time to say no and when is the right time to say yes, that's even harder. So great points. Thank you, everyone, for your contributions. Ira, thank you so much for hosting this. These types of conversations move the field forward. It's cross-pollination. We get to learn from people like Richard, John Minter, Kevin Plancher, Russ Bodner, James, Chris, just so many good thought leaders on this
Not Herrick.
panel.
He's full of crap. Don't listen to Herrick.
Oh, Herrick too. No,
Don't
Herrick.
listen to me.
Thank you,
No,
Dr.
don't listen
Bush.
to him.
Thank you.
Hi, buddy.
Love you
Loved
too.
Love you too.
Well, this is great. I really want Nate, phenomenal job. This was a fantastic session, one that we may revisit at another time. So I want to say thank you to everybody, and have a good night.